Thailand. Thailand is a Southeast Asian country whose neighbors are Cambodia, Laos, Myanmar, and Malaysia. It covers 120,000 square kilometers and has an estimated population of 69 million people who speak the official language Thai. 94% of the population is Buddhist. This makes it the world's 21st most populous country. Its capital city and administrative area is Bangkok. Thailand is known for its touristic destinations, in its tropical beaches, royal palaces, ornate temples, amongst others. But that is not what brought me to Thailand. In 2002, Thailand set itself apart from other middle-income countries by implementing the universal health coverage for different population groups in the country. 16 years later, almost 100% of Thai people enjoy access to healthcare without incurring catastrophic out-of-pocket expenditure. How did Thailand take this bold step despite a low gross national income per capita at the time?
Only when the public sector service is good enough and distributed all over, accessible, that it can be successful. If the quality of service is bad, no one wants to go to a slaughterhouse.
Dr. Suwit is the former Deputy Permanent Secretary of the Thai Ministry of Public Health in 2000 to 2003 and was instrumental in the implementation of Thailand's universal health coverage. Currently, he is the chair of the International Health Policy Foundation and Health Intervention and Technology Assessment Foundation.
Universal health coverage means universal access to essential and quality health services and health technologies without financial barrier. So the first leg is the access leg. You must have the facilities, right, available. The second leg is financial protection. You don't have to pay so much that you go bankrupt. You need two prongs. So the two prongs are developed in parallel in Thailand.
Thailand started its universal health coverage journey in 1975 when the government provided money to subsidize the poor people in order for them to access health services while investing in developing, equipping and improving the public health facilities at the same time. At the time, Dr. Suwit was the sole doctor managing a hospital with a 10-bed capacity, including 7 other staff. He had an operating budget of $1,000 annually for a population of 200,000 people.
$1,000 a year of budget, operating budget, excluding the salary, the electricity, utility. $1,000 a year. How long can I survive to buy drugs? See? So this additional money for the poor add up 1,000 to about 3,000 to 5,000. still talking of money, right? But it's quite big in those days. And they have also invest to improve the facilities. Hire more staff for us. Operation room, everything, even have a car.
The health system here in Thailand is no different in structure from the Kenyan health system. Here where we are is the Chantanimit Rural Health Center. This is the equivalent of a rural health center in Kenya. It offers primary care services to the community. The catchment area here is about 12,000 Thai people. This particular facility refers its patients to the equivalent of a provincial hospital. The difference with that provincial hospital and what we have in Kenya is that the provincial hospital not only offers secondary health care services, but it also offers advanced care services, that is cardiac, newborn, cancer, and trauma services. Now, let me take you through what this particular health facility has to offer. This here is their emergency room. In charge is a nurse who offers basic emergency care services, from resuscitation for a dehydrated patient or a dehydrated child to anyone in severe pain before referral, if that case warrants a referral. This is the doctor's room. Now, the doctor is present on Mondays and Tuesday to take care of the non-communicable disease clinic, where they look at hypertension and diabetes and dyslipidemia. This is people with high levels of cholesterol in their system. At the doctor's table is emergency contacts, including those of the police and fire department should they need them. There is an itemized list of all types of emergency drugs available for prescription. Dr. Kulawan is one of the 2 doctors that visit Chantanimit. She is a family medicine physician and acupuncturist.
Another day, the treatment is run by the family nurse and the public health officer. And the emergency care is about the minor trauma and dressing wound in the community. The people, the patient can come here every day and go to the center hospital for follow up them with the specialist and the surgeon.
The facility only operates as an outpatient unit that offers vaccinations, contraception services, diabetes and hypertension screening, safe sex talks to prevent teen pregnancies, monitoring growth and development in under 5s, to visiting schools in case of outbreaks, amongst others.
Rehabilitation, we have the Thai traditional medicine for the Thai massage and some medicine with Thai herb too.
In order to provide financial protection, the Thai government started with the poor before moving to the near poor. Its per capita was $400. In 2001, when they achieved universal health coverage, they had progressed to $2,000 per capita. The schemes that encompass Thailand's universal health coverage are either tax-based or the Social Security Scheme that is contributory. In this instance, those employed contribute 1.5% of their salary to the scheme, capped at a salary of 15,000 Thai baht, which is approximately $500, even if one earns more than that. The population groups of universal health coverage are Civil Servants Medical Benefit Scheme, Universal Coverage Scheme, Social Security Scheme. Those that are non-registered have 0.06 million, and in other schemes, 1.09 million people.
This system controls the price quite well, because we put the risk into the hand of the health facilities.
This fixed amount is 3,426 Thai baht per person, which is almost $114. Propaklau Hospital Chantaburi serves a population of 1 million people and therefore gets an equivalent of $114 million per year. Dr. Kringsak, the director of Propaklau Hospital and the chairman of the Rural Doctors Society, is of the opinion that this allocation to his hospital is sufficient to offer all health services to the population under his mandate, because prior to this, they didn't have such a budget.
The inpatient department is very systematic. We don't experience annual growth of more than 6%. We can therefore plan and work within our budgets efficiently with the annual projections of growth, inflation, and labor costs.
One of the major challenges that Thailand faced in ensuring universal health coverage, he says, was putting up a system that did not just ensure financial protection, but one that offered quality in all aspects of service.
We needed to do more to prevent diseases in order to reduce congestion in hospitals by offering quality community health services. It has to be quality service so that people don't have to go to private facilities.
Everyone is covered comprehensively under clear benefits package that range from the health promotion and disease prevention services, curative services for all diseases, including high-cost treatments and rehabilitation services.
So we have a National Drug System Committee chaired by the Prime Minister, and that committee determines which drug will be in the system. We call National Essential Drug List, which has around 800 chemicals, active ingredients.
In fact, Thailand does not rely on the Global Fund for its HIV/AIDS programs. It funds all first to third-line ARVs, CD4 tests, viral load tests, and drug-resistant tests. Only the active ingredients listed are covered by the universal health coverage schemes. The hospital directly incurs costs for anything prescribed outside the list, and at no point is the patient charged more. In Dr. Suwit's opinion, the 800 active ingredients are more than enough. He gives an example of a drug for a rare disease called Gaucher's that costs $100,000 per year. This is available in the essential drug list for anyone that needs it.
It's not only low price medicine. Essential means essential. Trastuzumab, which is for breast cancer, which has specific hormone receptor. Trastuzumab is very expensive, but it's included.
In a bid to maintain its health workforce, it is mandatory for Thailand's doctors to work for the government for at least 3 years in a rural area.
So you have to improve the service and make sure that the health workers are committed. They are committed. They work hard, they love the people, they work hard for the people. Universal health coverage cannot be successful without the commitment and the public spirit of health professionals. Money just part of the equation. Health professional is the main equation. Healthcare services is the main equation.
The doctors we interacted with had worked with government for the minimum 3 years, some up to 8, and a good number were still working for government. Non-medical health workforce like nurse practitioners and public health officers handle more than 50% of the primary healthcare in Thailand. They are trained and retained in the country. There are about 10 village volunteers per village who distribute up to 20 essential drugs, refill oral pills, and make sure that there are no water reservoirs that can breed mosquitoes, among other such duties. They are trained for between 7 days to 2 weeks and paid an honorarium of about $25 for transport. The Thai private health sector contributes only 10% of the health infrastructure. This is because Thailand was once a low middle-income country at some point without sustainable market for the private health services.
Only when our economy moved up, we used to have a very quick economic growth, so-called double-digit economic growth, around late 80s to mid-90s. Double-digit economic growth. Move up so fast. People have money in the pocket. Now when they have money in the pocket, they want better service. Better service doesn't mean better in quality, but mainly better in terms of hospitality.
Thailand's development in the health sector did not happen in isolation. Thailand had to shift from an import-led economy to an export-led one, therefore becoming self-sufficient. In 1985, for example, 25% of Thailand's budget went into servicing debt incurred both internationally and locally through bonds. 12 years later, in 1997, public debt had shrunk to 5%. A comparison between Thailand, South Africa, and Kenya in 2014 shows that Kenya still has a long way to go to improve its health sector. The public health expenditure as a percentage of government expenditure in Thailand was 14.2% in 2014 and 5.7% in Kenya. The out-of-pocket expenditure in health was 6.5% in Thailand and 32.2% in Kenya. Access to water source was 98% in Thailand, 93% in South Africa, and 58% in Kenya. Access to sanitation facilities was 93% in Thailand, 66% in South Africa, and 30% in Kenya.
So when someone tells you that, no, it's impossible to increase health budget, the government cannot, you have security, you have education, you have infrastructure, fixed percentage. Health used to have 4%, it has to be always 4%. Look at Thailand, it's not true. It depends on the government policy.
Over the years, since 2002, Thailand has changed its top leadership from 7 prime ministers and 14 ministers of public health, but the universal health coverage schemes in the country remain intact.
The schemes become owned by the people. They are happy to fight to death if anyone dare to touch this scheme, because it's their life now.
People and community participation is one of the 4 pillars of primary health care, after basic health services, appropriate technology, and intersectoral coordination. The concern of the Thai doctors now is for the public hospitals to become smart hospitals adapting to new technology in keeping with the developments in their private sector counterparts and the world. Apart from offering their support for Kenya, the doctors' advice to Kenya is to enact relevant legislation that supports UHC, in addition to having an institution that will work on healthcare reform, not just on finance, but also on managing the human resource for health. In Thailand, the National Health Security Office is tasked as the middleman to ensure health security for all Thai people. Looking at Kenya in comparison with Thailand, one lesson we bring back home is that we do not have to be a rich country in order to achieve universal health coverage. In fact, the Thai people say that being a poor country is the more reason why no one should be left behind, the more reason why the country needs to achieve universal health coverage. Dr. Masi Korir, KTN News, from Prapaklau Hospital, Chantaburi, Thailand.